Welcome to a Gobbet Opus 33, Incompletely Inured, from October 13th, 2008. Yesterday, Sunday, was a busy day that in no way had anything whatsoever to do with infectious diseases. Hard to believe that I could spend an entire day and not see something related to an infection. I guess I wasn't looking hard enough for some germ or other. Monday, it's back to work and no shortage of infection. Acute care medicine gets you used to all sorts of human condition. The 5 of the 6 senses, I am psychic, I have 6, are stimulated. Fortunately not taste, but often unpleasantly during rounds. We all get good at switching off those parts of the brain that lead to a less than professional response to the various sights, odors, sounds that flood the hospital. Sometimes you will walk onto the ward and the distinctive tang of melena, which is bloody diarrhea, will hit your first nerve. You inhale deeply and with appreciation. It is the fragrance of internal medicine. You are home in your element, the hospital. Today there were 2 sensory assaults I have not experienced for many years. The first was wet gangrene in a diabetic foot. The smell of putrefying flesh when it is still attached to the patient is distinctive. You know the microbiology of the infection instantly, as only the combination of anaerobes plus aerobes in dead tissue can make that smell. It is a mixed infection with stool organisms, and there are people who have done the olfactory studies to elucidate the microbiology of stench, sometimes using technology in lieu of their own nose. It is probably Bacteroides species that accounts for most of the funk, but the research is curiously minimal, and what chemicals cause the smell I cannot find. There's probably a complex melange like a good red wine. The treatment, like most anaerobic infections, is surgical, not infectious. I have become good at keeping my expression calm, not wrinkling my nose to the acrid smell coming off the foot of the bed, or the foot in the bed. The patients probably think I have Parkinson's. That's Dr. Crislip. He's so unexpressive. But basically, I'm trying not to puke. The other I still, after 25 years, cannot deal with. When someone has acute pneumonia, gives off those deep, hacking, wet coughs and brings up a large specimen, expels it into a tissue, and offers it to me to examine, I lose it. Still brings on my gag reflex better than a bottle of Ipecac. As a medical student, I had mentioned to my attending that I had an issue with sputum production, and he had been kind enough to provide, at my final in the history and physical class, with a patient that had trilobar pneumonia who coughed up his body weight in green sputum while I tried to do my final history and physical. Tears literally, not figuratively, but literally ran down my face as I tried, successfully I am proud to say, not to vomit. I passed, but I didn't pass out. Today was a little easier. The patient honked up a big wet loogie and offered it to me. I long ago learned to avert my eyes, stare off into the middle distance, and politely decline the offer, explaining that sputum is my one picadillo. Superman has kryptonite, I have sputum, and that the patient will probably not want to examine my last meal in exchange for an opportunity to look at his pulmonary secretions. They have always understood and seem to appreciate my honesty, or they are too kind to call me a wimp. My weakness is well known in the hospital, and the respiratory therapists and nurses derive no end of pleasure from my inability to deal with pulmonary secretions, enjoying the occasional opportunity to display a juicy sputum specimen to me. As an ID doc, they tell me I should be comfortable with all things pus, including sputum. I always tell them that I'm an infectious disease doctor, and pus is a theoretical construct, and, by the way, my vanity license plate. Others collect it for me. The lab analyzes it, and I determine what to do with it. I want to keep it that way. Relevant articles for this podcast are the Journal of Wound Care, Microbial Involvement in Chronic Wound Malodor, the Journal of Clinical Microbiology, Clinical and Microbiologic Features of Necrotizing Fasciitis, and the Journal of Endodontics, Association of Odor from Infected Root Canal, analyzed by an electronic nose with isolated bacteria. And so ends another Gobbet Opus.